Among the more significant social movements of the last 20-some years of the 20th century, as well as the early years of the 21st century in Wisconsin and the United States, has been the NAMI movement. And with the establishment of NAMI National in 1979, here in Madison, Wisconsin, families, consumers, including patients, clients, providers, and friends brought a focus to bear on the brain disorders of the serious and persistent mental illness. Well, my guest, Nancy Abraham, has devoted more than 43 years of her life as an internationally renowned advocate around issues of mental illness. She's one of the founding members of the organization that became the National Alliance on Mental Illness, or NAMI, a group that had its beginnings in the late 1970s and early 1980s in Madison and Wisconsin. Now, in the 1970s, most treatment was exclusively through private psychiatrists. There was very little community-based treatment. And in 1974, Nancy's son Dylan was diagnosed when he was 18. At the time, no organization existed that spoke to the needs of mental health consumers and their families. There were only organizations run by and serving professionals. Family and individual voices needed to be heard. Not only were people with mental illness stigmatized, but parents were often blamed for their children's mental illness, told, "You're sick too." And Nancy and her colleagues resolved to change that. Now, Nancy's given hundreds of interviews and presentations on this subject, many of them in collaboration with her son Dylan. Here in Wisconsin, as is true all around the country, thousands of people have been educated about mental illness, received support from their peers, and become active advocates.
Right.
Well, Nancy Abraham, hey, welcome. It's great to be in conversation with you today.
Oh, thank you. Thank you for bringing me in at this late stage of my life.
Well, why don't we start in a basic place for someone who's not familiar with NAMI, and what is the significance of the acronym NAMI?
The significance is that it is the French word for friend, and I don't always pronounce it correctly because French is not my thing. But it's wonderful that we right away in 1977, when we formed the Alliance for the Mentally Ill in Dane County, it was determined that the acronym would be NAMI, and specifically because of the word friend. So from the beginning, we saw ourselves as being very supportive of families and of individuals with the brain disorders of serious and persistent mental illness.
Now, just a distinction, I introduced it as the National Alliance on Mental Illness about a decade ago. That was a change, a subtle change, but
that's correct.
An important one from a consumer perspective, I guess.
That's right. That's right. The acronym still remained, and,
right.
and that to me certainly was very important. But there were consumers, not all consumers of services for mental illness, who felt that that was pejorative, mentally ill, rather than on mental illness. So
right.
That was the reason for the change. But always we say NAMI or AMI, so people don't don't necessarily know. But yeah, that was what the result was. Mm-hmm.
So the other piece of symbolism I wanted to bring in is an important one. The statewide newsletter, and we're going to be primarily focused on NAMI Wisconsin today, although we're going to talk about both the local and the national levels of all of this. But the logo for that and the name of the newsletter was the iris. What's the significance of the iris?
Well, that's because of the background of Vincent van Gogh, the very famous artist, who undoubtedly experienced severe mental illness. I mean, that's a retrospective look, of course, but so that's really an honor to be focused on the iris. And there was a period of time in NAMI Wisconsin's history where we were sort of the storefront, so to speak, for other affiliates around the country who wished to use the iris, actual irises, as other groups might have the poppy or something, and would buy large supplies for their affiliates to hand out in front of grocery stores or at meetings. So that we served in that role along with all the other things that NAMI Wisconsin did for a period of years.
Oh, what a beautiful symbol.
Yeah.
And it evokes hope, creativity, all kinds of other wonderful
Right,
images.
right.
Yeah. Well, what we're going to try to do in the course of this conversation, of course, that we're many partners in this process, and we'll have a chance just to touch on some of those folks, kind of as representative of things. But what we like to do, as much as we can, I guess, is to focus in on your perspective and your story, because that's really central to how an organization like AMI got started. And we can just begin with your personal journey, going back to 1974.
Yeah. The reason I ended up being involved is I try to think how horrible it was when Dylan first manifested what was diagnosed as schizophrenia. There's been some modification to schizoaffective, which in some ways is kind of like having both schizophrenia and bipolar, sort of. But yes, it just lands like a bombshell in one's life, and especially if we look back to 1974, when, as you said in the introduction, there were no organizations for families who were experiencing having someone with a brain disorder of a serious mental illness. So for the first 3 years that Dylan was ill, we were working with private psychiatrists, and I always want to make it very clear that the psychiatrists were excellent. Their work was excellent. But it really is difficult to care for someone and to really be involved in helping them succeed, move forward, be responsive when medical people need to be responsive to changes or the need for changes in medications and the seasonal kinds of things that can occur. Such as in Dylan's case, March and fall seem to be more difficult times where it almost seems like there's an exacerbation, even under really good medical care and really careful monitoring of medications. So by the time that I was asked by a woman in Extension who worked with Harriet Shetler whether I would be interested in joining with some people to think about forming a local support group in Dane County, I was ready.
Yeah.
Because it had become very clear to me that neither I nor Dylan nor very excellent private psychiatrist could do it alone. It just isn't enough. And so we met one evening, 12 people, at the Cuba Club, one of those wonderful supper clubs on University Avenue. The supper club doesn't exist anymore, but University Avenue does. Wild place now, traffic-wise. But anyway, and ironically, on that very same day that we met in the evening, Dylan was meeting with Dr. William Knadler, the chief psychiatrist of the PAC Program of Assertive Community Treatment. So, I mean, it was a wonderful serendipity that our lives, would take on more support, more help, and all of that occurring on the same day.
So just to punctuate, I think the arc of our narrative today, again, is going to contrast the way things were in the 70s. And part of that is the personal isolation that you and other family members, other individuals with mental illness were experiencing. And how that personal situation changed and what AMI did. And part of it also is just to talk about how our whole framework in this country on mental illness was in a very basic place that needed to be advanced, needed to embrace community solutions, essentially a community around these issues needed to be formed. And to punctuate, I think one of the things you shared with me that included in the introduction, again, previous to AMI being formed, most of the associations or the groups where people got together jointly, work on this issue, were for mental health professionals.
Yes.
And as you pointed out, there are really good people who are doing that work. But on the other hand, the whole construct of a situation like that is you have people telling you what's best for you, and not necessarily, again, a very professional perspective, but not drawing on the strengths and the insights and the resources that family members and people with mental illness had to bring to bear.
Well, I think, in fairness to the medical profession and psychiatry, though I didn't feel so fair sometimes, but it had to do with the training also of psychiatrists. And there was, running through that training, that mothers were responsible if schizophrenia manifested, that there was such a thing as schizophrenic mothers. And if I'm remembering correctly at my advanced age, that was based on 3 situations, never further replicated in any studies. So there was kind of a prevailing attitude. It might not always have been expressed, though many times it could have been to other people, that, the family, the parents had caused one of these severe mental illnesses. So that added to the difficulty that families were experiencing. And there were some people at the time in the profession, not all by any means, who were, as you said earlier, saying that the family, the parents were ill.
Yeah.
Well, I suppose in some cases that might be true if we realize and remember that there are genetics involved and can be pretty strongly loaded in some of the serious mental illnesses. So, but aside from that, no, so that made it difficult for families to step out.
Well, it just strikes me that in many ways, those of you who formed NAMI were trying to reframe a lot of basic understandings. When we talked a while back about all of this too, I think you were just saying sort of a behavioral approach is often somewhat wrong-headed, and it ignores the realities of brain disorders, the causes. It distracts us from getting at the root of what's going on here.
Right, yeah, very much that the idea that, you cause the behavior.
Right.
I never had that said to me, but there was that prevailing myth or attitude or thread or core running through the society at large, so that was, yes, definitely something that we wanted to make clear, that we could demonstrate, we could say, hey, our relative did this and this and this, and was accomplished in these areas before the first episode occurred, and then there was a dramatic change.
Yeah.
In the individual's behavior, outlook, thinking process that was extreme beyond what one had seen. In our case, Dylan, did quite well in school until about 2 years before the first episode occurred. So the last year of high school was very difficult. And that was very unusual.
Yeah.
And that was hard to figure out. What is this? Is this senioritis? And that's what everybody, thought.
Yeah.
As parents, as a parent, if I talked to other parents, oh, that's just senioritis. But it wasn't just quote unquote senioritis. It was a change in the brain.
Yeah.
And it made it difficult for him to study, whereas almost up to the point where his brain began to change, he didn't have literally a photographic memory, but really very close. So all of that changed. So that when he became ill, he was somebody who taught himself to add and subtract as a real little kid, watching the odometer on the car. In the old days, when children could stand up in the back, they could see not the current days. And then he could barely add or subtract initially after he became ill. So things like that. There were learning changes, and that was not something you ever heard.
Yeah.
Now, probably, frontline researchers were seeing that, but in terms of, again, the society at large, or what was being communicated to families, you weren't hearing that at all. So that was significant, very significant.
So you're identifying one of a number of things we'll talk about, sort of gaps in our understanding.
Yes.
lack of peer support, lack of places you can go to get basic
Right.
information about what's going on.
Right. Yeah, and of course there wasn't the internet,
Right?
which I still don't really use. But
And we'll talk about that later. There are pros and cons about all the
That's
social media
right,
stuff.
that's right, yeah.
As you said, you're a social person, and that's kind of fundamental to everything that's going on.
Yeah.
The social connections you made here.
Right. Yeah.
Well, just to back up to talk just about this family connection, though, I think obviously there is a good side, whether it's the practice of medicine in general. A couple of my good friends, Gina and Linda Farley, were part of family practice medicine, and this was sort of taking the whole family, the whole community, into consideration when you're giving good health care. And so, in some sense, understanding that the whole family is involved when an individual is experiencing mental illness is really fundamental to this. But as you said, it's not a matter of trying to place blame or responsibility or other things, but the whole idea behind NAMI is being in partnership with the affected person and other families that are going through this. In a positive way, bringing out the best of what family means.
Right, and I do want to emphasize that when we formed the local in Dane County NAMI in 1977, the main thrust, the goals, the mission for advocacy, education, and support.
Right.
And those still remain the main aspects in the national NAMI, in the Wisconsin NAMI, or NAMI.
Yep.
That has not changed because those are really important, very important aspects. And in the early years of NAMI Dane County, there hadn't been any support groups. So there were board meetings where people were crying, upset, carrying on, thinking through strategies. Who's going to be going to the 5142 board, because that was a board that we had prior to the Human Needs Committee of the Dane County Board that focused on the statute, the 5142 statute, i.e. mental illness, people with mental illness. So, and we monitored those 5142 board meetings for years, or spoke at them, or testified. And I remember testifying already in February of 1978. So that was very early on in the whole movement, of getting up in front of a public group and saying, I am the parent of.
And you're alluding to this, but you were telling me last time we spoke, NAMI in many ways can't be characterized as an agency, but it's an organization.
Absolutely.
What's the distinction there, or how does that fit into what you've been describing?
There are things after 40 years of being involved. I mean, Dylan's been ill for something over 43 years, but being involved in the whole NAMI movement, that I sense kind of a change from it's being an organization of members to an agency. Not that the words have been included, but we now offer signature education programs that come down from the national to the states and then to the affiliates within a state. And for the numbers of people who have been educated in those signature programs, whether you're a family member, whether you're a peer, that is somebody with an illness where you've had the peer-to-peer, whether it's been in our own voices, whether it was, we did a couple of trainings here for professionals. I mean, even like in the state of Wisconsin alone, it's like there should be, I'm making up the number, but it's close. There should be like 100,000 members of NAMI Wisconsin, but of course there aren't. It seems to me as a long timer, and I don't mean this negatively, it's just that it's an observation over time that more people come and they take a course, which is good because the individuals get more information much more quickly and in more depth and more breadth than one could in the early days. I mean, and that's really important. And some people then become very active in their local areas in the state. But in terms of a membership roster, where one can say, we have this strength as one goes to advocate or to educate people who have the power to change things, that has not expanded in the same way that the education of people out in the field has. And I mean, that's wonderful that people are taking advantage of those signature education programs. But I also would like to see them, what shall I say, taking responsibility for more of an involvement. And there are those who are, but it seems to me there could be far more. There could be tens of thousands.
And I think some of the key to that, and part of the reason why we're doing this, we're trying to capture this history, is sometimes you need to come full circle with movements, whether it's the Black Civil Rights Movement. Another analogy we were making last time we talked is the movement that sprung up to deal with the AIDS crisis. And I know in the context of that latter movement, there's this dynamic tension because there had been concerns among folks that were involved from the very beginning that the advocacy, the mutual support, the people coming together to change things that were wrong, that gets lost over time. You become more of a service-delivering one-way agency. And so it seems like it's really important for people to understand that's a lot of the power of a group like NAMI. Those of you who not only were trying to figure out what are the realities of this time and how do we deal with them, but how can we change things and make things better?
Yeah, and I think we're really doing history within this discussion. However, we are at a time in our country where numbers of people dedicated to an area of grave concern is really important. And somehow people are going to have to come out of the woodwork to preserve the developments that we have made. And the developments we have made of more community-based treatment are insufficient. Insufficient for the numbers of people who have a brain disorder that's really serious and that needs very good care and ongoing treatment, at least under our still limited knowledge. I mean, we have far more knowledge than we did 40 years ago. But in terms of what can be learned about an organ of the body as complicated as the brain, there is much, much more to learn. But we're not necessarily implementing what we've learned to the advantage and to the help of people who need it. Otherwise, would we have so many people in jails and prisons?
So many homeless people?
And so many homeless people. I mean, so it's, I guess I got tied in early, and I can't seem to get out of it.
43 years is a pretty long time.
So yeah, so that's one of the drums that I really want to keep beating, that people need to, once they get educated, now not everyone can, but to give back. And to give back in time and energy, if people are able. To understand that we're not done. And that actually we're under attack right now. You know, so it's we need to marshal the troops, so to speak.
Absolutely. Well, there are a number of threads we'll pick up on as we move through the conversation. And again, looking at the here and now, I think is an important way to end this discussion and again, to draw on those lessons and where we can go from here. I guess, you know, because I think one of the things you were impressed on me when we've spoken about this before is some of the unique perspectives you bring as a parent. And I guess I want to backtrack to that just briefly. Again, to talk about those early years, you were mentioning people would come to board meetings, and very quickly you realized these were highly emotional, highly charged issues for people because they affected people very personally. And I know one of the things I was reading about that you discussed in an interview is just the revelation that comes after you have an adult child who's experiencing mental illness, and your fears, your concerns about will they be getting the support they need? Will there be someone to look after them after you're gone?
Oh, absolutely, absolutely. It's and people are actually in the early stages. The individual, surely, and family are living a nightmare.
Yeah.
A nightmare that does not end. You don't wake up and have it over with. And people need a lot of care and support and understanding to, live through that and work through that. And that's, included now in like a family-to-family course, 12-week course through NAMI kind of thing. But we had to figure that out ourselves, that, you're going through all those stages of grief because you are really, if you want to move ahead, finally, I had to bury the person I knew. I mean, psychologically, in my own mind. Now, some people would disagree with that, but that's what I had to do.
Yeah.
Because to keep expecting that I was going to see the same person, that wasn't going to occur, at least not in the very early years, like first 10 years or whatever. I mean, you could see flashes of, but it's just not the same.
Yeah.
So that's like, in a sense, burying somebody. People don't like to hear that while they're alive. But if you don't, I guess a better way to say it is, if you don't adjust your expectations, if you don't try to look at it differently, if you don't learn how to rewrite your own story, and if you don't have the strength, and a lot of people don't, it's not easy. Hopefully it's quote unquote easier now, but it's not easier now if people are unable to get their relative into care.
Yeah.
So, it's very, very difficult.
Yeah, I mean, again, there are a number of threads to pick up on here, but one of them is the need for perseverance, and that's true of any social movement.
Yes.
We tend to think of Band-Aid solutions, or if something takes longer than 2 weeks to figure out and isn't neatly tied up, that it's hard for us to stay with these things.
Yes, very hard. I don't know if it's appropriate to say it right now. I used to say, well, if there was a lot going on in the Capitol, you needed to sleep in the Capitol and never go to the bathroom so that you didn't miss something that might be changed in a moment, kind of thing. It's a little bit of an overstatement, but it is saying you need to be vigilant.
So I think you've alluded to this, but again, one of the things that strikes me about AMI is, first of all, of course, you and other folks are motivated out of your love for the affected individual.
Absolutely.
And that's a bottom line. But one of the things you've impressed on me, too, is there is a role for this organization to support you as a parent or a sibling or another loved one. In some ways, it's a distinctive perspective. It's something, it's different set of priorities that need to be brought to bear.
Yeah, absolutely. And I think one has to be concerned about the broader society, the common good. I suppose one could walk away because, I never could walk away, even though Dylan is getting care, because I'm thinking there are all these other people who aren't. It's not right. We have to make that happen. The people who need the care are getting it, and they're not. I still hear stories about people who cannot get their relative into care. And people will say, well, it's because of It's because of the statutes. It's because of deinstitutionalization. You'll still hear people saying we should not have deinstitutionalized people. And that's another one of those things I can get on my soapbox about.
So again, in the 60s and 70s, there was a sea change. Very
Right.
often, the solution was to put someone in what was a long time ago called an asylum, but
Right.
but essentially kind of
Out of sight.
out of sight, out of mind.
Yeah.
Yeah. And so good things happened with this notion of deinstitutionalization. But again, as you've alluded to, community support needed to replace that. It often didn't come to the extent that it needed to.
Right. And we know what to do. I mean, a program like PACT, Program of Assertive Community Treatment, has demonstrated how to work with people with serious mental illness in the community, and it is evidence-based. Programs such as Yahara House, the Clubhouse model, has demonstrated how to work effectively with, again, certain populations. So it's kind of like we know what to do,
Yeah.
but we don't do enough of it. And I sometimes wonder, is there not sufficient understanding, and how does one help the society as a whole understand that because these are disorders for which we do not have cures at this point, and we don't even have all the causes. I mean, we have some hints of what might cause, but we don't really. So, therefore, many people are going to need lifelong care.
Yeah.
Or support. I mean, I say care, I know that many consumers might want to hear support. Well, both, depending on the severity in a given individual's life. But certainly support. And different people's disorders are more severe than other people's, there's that, just like with other illnesses.
Yeah.
Or diseases. So, so.
But would I touch on something you talked about, again, from the perspective of a loved one or a parent who sees someone in need, who's struggling because of a brain disorder? It can be a catch-22, because very often the brain disorder makes someone reticent to seek treatment or to see what's going on. You were telling me a story in terms of Dylan's journey early on in terms of the PACT program, this program of assertive community treatment that was pioneered here in Wisconsin,
Right.
the Mendoza Mental Health Institute.
Right.
That it was kind of hit and miss. It would become engaged and would pull out for a time. But you mentioned a conversation that Dylan had early on with an attorney, I think it was his guardian ad litem. And could you continue that story a bit?
Yeah. Well, firstly, let me say Dylan has always been in treatment voluntarily.
Yeah.
We never did need to take that step of the involuntary commitment, for which I was grateful, because that's very difficult. Although there are times that needs to happen to help the person. But yes, so Dylan had stopped out of the program, and it looked as though he was not going to sign back in. And I mean, I was frantic. And so I talked with my attorney at the time, or the attorney that I talked with at the time, who then had selected someone who could be the guardian ad litem. And, but I explained, while crying like mad to the attorney, I don't want to commit him. I want him to be in the treatment program, but on a voluntary basis. Because I just felt he would do better if we're back in voluntarily. And then I had a call from the individual who would have been the guardian ad litem. And I explained to that individual at great length that I didn't really want to commit him. What I wanted was for him to sign back in voluntarily. And finally that person understood where I was coming from. And then that person talked to Dylan and explained that I really wanted him to sign back in voluntarily. And then Dylan called me later and said, well, I thought if that many people really cared about me, then I would sign back in.
Right.
Which he did. So that was a relief to me.
It just strikes me that's key to why AMI works.
Yeah.
It really is a partnership. It is a community of support that surrounds someone to give them that possibility to realize there are people that believe in them and want to see what's best.
Right, right.
Yeah.
But it takes time.
Yeah.
You know, it isn't always an instant. And thinking, too, to what we had just been talking about previously, the more teams we can have, crisis teams, teams on the street to develop trust with people who are not in treatment, who could then, you know, be eased into it, that's really important. And there was a time when we did have some street teams, and now I think we're back to that, or getting back to that in Dane County. And I'm not talking about the CIT right now, the crisis intervention. I'm talking about teams that are working to get people into treatment who have been reluctant or who don't understand, or the disease, disorder, the illness, whichever of those words one likes best, prevent that or make it difficult for an individual to understand that at a given time. So with trust being built, an individual can then move at some point, hopefully, into treatment.
And that may be hard if the system has failed someone, if the programs haven't been implemented fully the way they need to be.
Right.
Once a person has that bad experience, it's hard to get them re-engaged.
Right, right.
But again, that's why this comprehensive approach that seeks to deal with the realities as they are, but also tries to change the system, tries to put things in place that will make this a better situation.
Right.
One of the other things, coming back to the program of assertive community treatment, the PACT program that you talked about, is just the observation that this is actually a much more cost-effective way to address these problems.
Yes, and any good treatment is much more cost-effective than people in and out of hospitals or in and out of jails or incarcerated. I mean, God forbid. You know, the number of people, at say Mendota in the forensic unit, we would have to bring in somebody who's an expert there. But many of those people were not in care and treatment beforehand. And that's really a societal sin from my perspective.
Yeah.
You know.
Well, let's again, going back to that period of the late 70s and the early 80s, and I think you had a great handle on it in terms of these three fundamental missions that NAMI had: support, education, and advocacy.
Right.
Why don't we break those down and say what that meant? And why don't we start with education? One of the things you were telling me, for example, in the 70s, and maybe even still, trainings that continued for quite some time, for example, was this myth that schizophrenia and split personality were the same thing. I mean, some really fundamental misunderstandings about things like this.
Right. Well, in terms of the signature programs, education programs that come out of NAMI, those did not start until the 90s.
Okay.
So there were people, individual people. In fact, in the national AMI, we had a curriculum and training committee. And so we always met before the start of the national conference. And there were people from various schools of nursing, departments of psychology, social work, OT, some medical schools, and then people like who were not, I'm not a professional in any of the medical arenas, but a parent, and people like Dylan, consumers, who would meet and we would talk about educating what people had done, where they'd done it, that kind of thing. And we even recognized an outstanding program in a given university or college, whether it was nursing or whatever. So that was going on very strongly in the 80s into the early 90s. So both Dylan and I did a lot of educating.
Yeah.
Going into classes at universities, he going into high school, talking at conferences, talking to professional groups. And that's how the education was going on before the signature programs.
Okay.
And then there was education really coming through the newsletters or the magazines of local, state, national kind of thing, and through program meetings of educating ourselves. We had in Dane County, for example, and probably other affiliates around the state and around the country. But we would bring in a professional to talk about schizophrenia or bipolar or what's going on in helping people who are homeless. So there was a self-education going on all along in those ways also, as well as educating out.
And education doesn't exist in isolation to the support aspect or to the advocacy approach.
Right.
So when you had someone come in, was talking about the realities of the current system, efforts to get legislation passed, again, ways that could try to broaden the array of services available to people. Education was maybe the first step, but then that led to advocacy. And of course, there was also a component that also tied together with what support meant, because support meant coming together and working on this stuff together.
Right. And in Wisconsin, with people like from the, well, now it's Disability Rights Wisconsin. Was it Wisconsin Coalition prior to that?
For advocacy, yeah.
So, you know, there were people working with us, and Diane Greenlee was a member of NAMI, but very involved with Bev Young and some other people in working toward the community support programs that we have in this state, which took on a lot, but not absolutely everything that PACT has demonstrated. So that was one of these many faceted, many people playing very important roles to get those programs up and running, you know, in the state of Wisconsin.
So, you know, we should just note that what we're doing here in terms of the storytelling is part of a larger project that's been going on for several years now. The stimulus for this was the 25th anniversary of the American for Disabilities Act.
Right.
But to look at the history of mental health advocacy in Wisconsin, and so again, you're alluding to this. NAMI was crucial, was fundamental to a lot of the advocacy and the changes that occurred. But you did that, of course, in partnership with a whole variety of people.
Oh, right, absolutely. You can't say it was one person or 12 people or 50 people, because there were legislators who were very helpful also.
Yep.
You know, it's just...
And then people within the human services departments and other professionals who were drawn to this profession because they wanted to make a difference.
That's right.
Yeah.
That's right, yeah. I mean, if we were to tabulate all the people who...
Right.
Yeah, and that's why I say we could have an army, so to speak, if we look at all the people who were initially involved through the years and all the people who have received education through the NAMI signature education programs, and I mean it's...
Yeah. It's a huge story.
Yes.
And we should encourage folks who are watching this to come to the NAMIWisconsin.org website.
Right.
As a copy of essentially a timeline and description and history.
I should just, yes, this wonderful, wonderful Wisconsin history of advocacy and mental health services.
There you go.
With for people with mental illness. I mean, and there's a very pale iris in the center of the white state of Wisconsin on the cover. But yeah, and this took a lot of effort on a fair number of people's parts to make this come to finally closure or or finality at this stage of its history. Yeah.
So we mentioned this in passing, but again, there's a significance in terms of the Wisconsin-based history here. There were some very pioneering things that were done in many different ways, including the formation of AMI. but we should say this was a national movement in many ways that had its roots here. So to flash ahead now, there are chapters in every state in the country, hundreds of chapters of AMI. There's a national office that's very active, but all of it had its roots back here. I guess part of what I'm alluding to is, I think any organization that's especially effective on an issue like this has a local aspect, a state aspect, and a national aspect.
Right. And I'm back to an organization.
Right.
An organization, yeah. Which means I have a responsibility. I need to have input. I need to stay with it. I need to be concerned about the greater good.
Yeah.
That's my personal.
I mean, you described this as a social movement, one of the most significant social movements of the late 20th and early 21st
and I know
century.
Harriet thought so too.
Yeah.
And I'm sure others also, but yeah, Harriet Shetler too. Yes, because there was nothing for families, and there was not much that you can't discredit the asylums, you can't discredit the hospitals where people were really trying. That's unfair because it was another time. But we needed to get it out in the light.
Yeah.
And that's why I'd like to get back to the deinstitutionalization. And I have had to argue that with a fair number of people, not necessarily in the movement, but because when you hide people away, away from the light, then things don't change, or we're not forced to look at it. What are the situations? What are the problems? And so, while it was not done in the way that it was meant to be done, the mental health centers, that whole Mental Health Center Act, was meant to deal with those most ill.
Yeah.
And that did not necessarily happen. It may have happened in some places with some staff who were committed to that concept, but that did not happen across the board, and should have. That's quickly saying what should have happened, but
sure.
But it meant we as a society needed to begin to really look at what is or are these situations and conditions that people who experience the illnesses are dealing with, and what are their families dealing with, and what are their friends dealing with. So we still have a long way to go in making that right, but we couldn't be where we are if we'd not gone into the deinstitutionalization movement. At least I don't think we could be.
Just a quick aside on that, I had a chance to look at some family letters from the 1860s and 1870s. I think a great uncle Jacob, he had a very similar situation, I think, to what you're describing, to the onset of Dylan's illness. A brilliant young man, was succeeding and writing, at the time, of course, people wrote these wonderfully lyrical letters that were so descriptive of what was going on back and forth. You can see how much his family cared about him and how excited they were about who he was becoming. But when a break happened, when something happened, he went into an asylum, and there was essentially a silence for 50 years.
Right.
And that's part of what we're trying to undo with the institutionalization, that there are things that can be done.
Right.
But again, to punctuate, what you're saying, deinstitutionalization was the first step. But it sounds like there were other steps that need to be taken to fill that vacuum in terms of community support.
And we're supposed to have been.
And that still hasn't happened to the extent that it needs to, right?
Right, not to the extent that it needs to. Because the population has grown, so going to be more people who need it, and we don't have the cures yet, so people need ongoing support.
You had outlined for me, I think, some of the underlying reasons for the formation of this grassroots movement, and I think we've touched on some of this, but let's just make sure we're talking about this, because again, I think part of what we're trying to do with this arc of the narrative is to take what things were like in say the 70s and and the directions that we've tried to go, and how NAMI has played a role in that.
Oh yes, indeed.
So one of the things you mentioned was medication. For some people experiencing mental illness, that's a dilemma because medications can have horrible side effects.
Right.
So how does a group like NAMI intersect with making medications more effective, having more options available? You're kind of sharing information.
Well, especially through the national NAMI, there's been a real push on research. Although right now, there's not, at least a couple of years ago, there was, maybe 2 or 3 years ago, there was almost no research going on of any consequence for new and better medications.
Yeah.
Supposedly because the pharmaceuticals could not earn enough money. So I'm not up to date now, like 3 years later, to know whether there have been any changes in that arena. But that is a problem. We, along with other organizations, pushed very hard to have a focus of research on the brain. And senior President Bush, I can never remember the number, but anyway,
right.
Senior President Bush did sign the Decade of the Brain in 1990, I think that was. And there much more money was allocated for research into causes and cures of the brain disorders of mental illness. Also, along with other groups, National NAMI helped to bring up what was known as NARSAD, the National Association for Research into Schizophrenia and Depressive Disorders. Mm-hmm. That name has now been changed to Brain and Behavior. It's like we're coming around again.
Okay.
But that has had a real focus on young investigators, and there are lots of different areas of research going on through NARSAD, now Brain and Behavior funded research. It was a little alarming to think that NIH funds were going to be cut under the current administration at the national level. Now, it seems that that's been ameliorated a bit because we also, as a national, fought hard to bring research back under NIH as it related to mental illnesses, mm-hmm. brain disorders. And that did occur also. I forget just what year or years, but so yeah, it's...
Without getting too bogged down to the history of different mm-hmm. medications and things, there was, is it right, there was essentially a breakthrough around about 1990 in terms of new drug that came on the scene for schizophrenia?
Well, there was a breakthrough in the United States of America for the use of clozaril or clozapine, but had been being used in at least some European countries for about 15 years prior to that. And that was the first major atypical antipsychotic released in many, there had been what we call the typical antipsychotics, and this now was the first of the atypicals. So yes, that has made a difference in the lives of many people with schizophrenia, and I think even some with bipolar sometimes, yeah.
And in terms of bipolar treatment, bipolar illness, there are drugs that were used in the treatment of seizure disorders,
right.
other things
right.
that have proved promising in terms
right.
of that.
Right. Mm-hmm.
Again, despite sometimes the tendency to make it behavioral or to fit into a matrix that maybe is about managed care or about other things.
Yeah.
Where was I going with this?
But the behavioral bothers me.
Yeah.
I have about a half a dozen soapbox items.
Yep.
And that's one of them. Isn't that interesting? We're back to behavior. That's where we came in. That's where we fought, to establish that we need to look at the brain in a broad-based way. We need to understand how it works.
So it's not that in Dylan's case or anybody else who's experiencing mental illness, that what you do in that sense, and what behavior is, how you approach it, how you're strategic in terms of seeking treatment, making adjustments to your life, that's okay. But it sounds like you're still coming back to the reason you got together in the first place in the 70s and 80s, to understand that many of these illnesses were brain disorders.
Right.
And I guess the analogy with physical illness is something else to come back to. Just
Absolutely.
To understand, we don't have any problems with taking medication for epilepsy or for diabetes or for other physical ailments. But there's still, to a certain extent, a stigma or hesitation to use that kind of approach, with mental illness.
Well, also, to what extent do people really understand that the brain is an organ of the body?
Uh-huh.
I mean, it is our most complex organ, right? And I don't begin to understand, but I do know it's the most complicated. I do know, that there are trillions of synapses, billions of neurons, over 100 or more chemicals isolated in the brain's biochemistry, 5 recognized neurotransmitter systems. Maybe there are others, that's not known. Well, I mean, how hard does one have to think to recognize that's very complex?
Yeah.
Yeah, that's very complex.
But I think the other thing this is linked to, one of the other areas of advocacy is getting health insurance coverage on parity for physical illness.
Right.
To a certain extent, when you understand some of the biological roots of mental illness, that just makes it a little more clear cut.
Right. Yeah.
Yeah.
Absolutely. And doesn't the brain control all of our body?
It's all tied together and all related.
So it's really comedic if it weren't so serious,
Yeah.
Yeah.
We're at about the hour mark,
right.
so we're going to take a break for just a second. I do want to come back, I think, describing the energy of that 1979 meeting again, and kind of the arc, take us through the next, several decades, kinds of things that were happening at the level of NAMI. Anyway, a few loose threads. We'll come back to that in just a second.
All right.
All right.